Welcome and thank you for joining us. Our next presenter is Jennifer Miller. Dr. Miller is Professor of Pediatric Endocrinology at the University of Florida and spoke earlier in our conference. She is a well-recognized figure in the PWS community for her clinical and research contributions. She will be discussing the therapeutic response to DCCR in patients with Prader-Willi syndrome. Please welcome Dr. Miller.
Thank you so much. I really appreciate the opportunity to talk today. I'm going to do this. Let's see. Good? Can you see them? Yes? Somebody give me a thumbs up or something. All right, well.
Yes.
Yeah, all right, good. All right. So as you said, I'm going to be talking about the therapeutic response to DCCR in patients with Prader-Willi prior to the onset of the COVID-19 pandemic. And if I could make my slides work, that would be excellent. There we go. All right, so DCCR, as you may remember from my talk yesterday, is the tablet formulation of the choline salt of its parent molecule diazoxide. And DCCR was formulated to allow for gradual absorption of the medicine over 24 hours rather than multiple times per day. DCCR's mechanism of action is that it works on potassium ATP channels. There are potassium ATP channels throughout the body, the most famous of which is the pancreatic beta cell, where diazoxide or DCCR works to reduce insulin secretion and decrease hyperinsulinism. But there are also potassium ATP channels in other areas of the body, such as the brain and the adipocytes, where DCCR works to decrease hyperphagia and body fat. So if you didn't see my talk yesterday, you're going to see it now, that the phase 3 program design was twofold. There was the C601 study, which was a multi-center randomized double-blind placebo-controlled study where patients were randomized 2-to-1 to receive either DCCR or placebo. And then if they finished the C601 trial, they were given the opportunity to go into the C602 trial, which was the open label safety extension trial. So 127 patients were randomized, 120 completed the C601 trial, and 115 entered the C602 trial. Right now, there are currently just over 100 that are still on C602 at a timeline that's approaching 3 years at many of the sites. So the reason that the company titled the slides about the impact prior to COVID-19 is because we all know, as Elizabeth discussed earlier today, that the COVID-19 pandemic had multiple effects on people with Prader-Willi and on their families. And so we know that some people did worse during COVID. As Elizabeth mentioned, you're right by the kitchen, it's right there, the siblings are eating, you're off routine. But some people actually did better. So there were people that at home, the food's locked and they have no opportunity to get it, but at school, they have more opportunity to steal it or get from other people. And so at home, they actually ended up doing better. So because of this sort of discrepant response that people with Prader-Willi syndrome had to the pandemic and quarantine, the company decided to look at the data, stopping it for anyone who had finished C601 prior to March 1st, 2020. So if you look at this table, it shows you the all data section on the left, which is the data that Soleno presented publicly in June of 2020 versus the second data set, which was the data that was cut for people who had finished prior to March 1st, 2020, when the quarantine started in the United States. And what you can see here is that it lists both the primary and secondary endpoints, the primary endpoint being hyperphagia questionnaire score, and secondary endpoints being the caregiver global impression of improvement, which Elizabeth discussed, is done by the providers, as well as the caregiver global impression of change, which was done by the parents, and then DEXA body fat was the third secondary endpoint. And what you can see is the data, when the data was cut prior to March 1st, that every single one of these endpoints, of both primary and secondary, were strongly statistically significant. So the change in hyperphagia score, global impression of improvement from providers, global impression of change from caregivers, and change in DEXA body fat. This is a waterfall plot showing the data. This is the data cut again before March 1st. And you can see that this is showing hyperphagia questionnaire score, and the lower the score, the better the improvement. And so you can see that the great majority of people who improved significantly on the hyperphagia questionnaire were on drug versus placebo. This is a responder analysis curve to look at what is a clinically significant response in a change in the hyperphagia questionnaire score. So this takes the Hyperphagia Questionnaire score and correlates it with a clinical outcome. And so what this shows is that a score of an improvement of 7 on the Hyperphagia Questionnaire score was considered clinically significant. And as you can see from this curve, that it was statistically significant that DCCR was superior to placebo in terms of bringing down the Hyperphagia Questionnaire score by at least 7. So this is the CGI rating. This is the one done by providers. And as you can see, the people who were on DCCR were rated more as more improved than those who were on placebo. As a matter of fact, most of the ones on placebo were rated as no change, 83%, which is good because they were on placebo, so you shouldn't see a change. So, so the DCCR again was superior to placebo. The caregiver questionnaire again showed significant changes or significant improvement in those on DCCR versus placebo. And again, this was just based on the caregiver's report as well. And I thought the way Elizabeth described it when she was talking about the Levo data was actually spot on. I love that description of why these two scores are so discrepant from one another in terms of the caregiver and provider scores. And because, you know, we as providers are seeing hundreds of patients with Prader-Willi and basing our scores on that general knowledge, where the parents only have access to their child and just basing it on what they see, and they're seeing their kid all the time. So it's a little bit more difficult to assess changes when you're seeing your kid all the time and they're your only, you know, they're your N of 1, if you will. And then this is the last secondary endpoint. This is body fat mass by DEXA. And what you can see is that DCCR significantly improved body fat mass by DEXA as compared to placebo, where the people on placebo actually had a slight increase in body fat mass during the 13 weeks of the study. This is looking at lean body mass by DEXA, and you can see again that DCCR improved lean body mass compared to placebo. And the graph on the right, the bar graph on the right shows you the lean body mass to fat mass ratio. Now this is interesting because at the beginning of the study, the lean to fat mass ratio for most people was about 50-50. So they had about equal amounts of lean body mass and fat mass. And after 13 weeks of DCCR, you can see that those on DCCR had significantly more lean body mass than fat mass, whereas those on placebo had no change in that ratio. And then this is my favorite part of the study. This is the behavioral endpoints from the study. So this was done using the Prader-Willi Syndrome Profile Questionnaire domain and the Developmental Behavioral Checklist. And what you see here is that DCCR improved all these behaviors that we consider sort of core fundamental behaviors of Prader-Willi syndrome: aggressive behaviors, anxiety, rigidity and irritability, compulsivity, disordered thinking. It also improves social relationships and communication amongst them and their peers and their family. So this was really very unexpected to me and really neat to see how many of these sort of what I call core symptoms of Prader-Willi were significantly improved with DCCR versus placebo. And in addition to all those questionnaires and DEXA scans, we also looked at some cardiometabolic endpoints because you know, we like numbers, and including leptin, insulin, and acylated ghrelin. And what you see here is that insulin, not shockingly, decreased on DCCR versus placebo, because that's what it does, is decrease insulin. But leptin also very strongly, significantly decreased on DCCR versus placebo. And I think this was probably a function of the fact that not only did body fat mass decrease, which is where leptin is made, but I think there was also likely some increased leptin sensitivity at the level of the blood-brain barrier, allowing the serum leptin level to be a little bit lower. Now, what's cool about this table is the acylated ghrelin. So acylated ghrelin is your hunger hormone. It makes you more hungry. And typically when one loses leptin by losing weight, acylated ghrelin goes up because your body wants to maintain homeostasis. So when you lose weight, you get more hungry. That's how it works, because your body wants to keep the fat mass that it has. That's why it's much easier to gain weight than it is to lose weight. And what you see here is that that didn't happen in this study. So leptin went down significantly and acylated ghrelin went down, so that there was no compensatory increased hunger response to the loss of fat mass. As a matter of fact, acylated ghrelin, like I said, went down. So that was really interesting to see. I mean, we knew it from the Hyperphagia Questionnaire scores, but it was still nice to see this marker validating that. And then adiponectin is one of those weird hormones that actually goes up. The healthier you are, the less body fat you have. And so adiponectin, you can see, went up significantly on DCCR versus placebo. These are the glycemic parameters. So there was obviously always some concern that when you're lowering insulin levels, you might be raising blood sugar levels, and you worry about potentially causing diabetes or something like that. And what you can see here is that insulin sensitivity in the green at the bottom increased significantly on DCCR versus placebo. And in the bar graph on the right, you can see that hemoglobin A1C, which is a measure of blood sugars over the past 3 months, did go up slightly on drug versus placebo, but it wasn't clinically significant. Fasting glucose also went up slightly, as expected. When you reduce insulin, you expect blood sugars to potentially go up, and they did, but again, not clinically significantly. This is looking at other meds that were added on during the study to treat potential side effects of the drug. So the side effects of the drug that are known are increased body hair, lower extremity edema or swelling, and high blood sugars. And what you can see here is that for hyperglycemia, there were 3 patients on DCCR and 1 on placebo that were started on an additional medication to help control the blood sugars. The medication was metformin, which is commonly used in Prader-Willi syndrome to control blood sugars. And so that's what that was. And then for the edema, no patients were on any long-term meds for it. 3 did do a very brief course of diuretic treatment to get some of the edema to go away. But the great majority who had edema, it was really non-significant to them and didn't cause any problems. So this is looking at blood pressure during the study, and you can see that there was really no changes between either systolic or diastolic blood pressure between baseline and 13 weeks or between DCCR and placebo. And the same is true for cholesterol, with the exception of, in the 13-week period of time, HDL cholesterol, which is your good cholesterol, which is a measure of metabolic health, actually went up, which is great. You want HDL to be higher, and it did get higher with DCCR versus placebo. This is a table looking at the adverse events during the study. And what you can see is that, as I mentioned before, the expected adverse events were the most common adverse events. So hypertrichosis, or increased body hair, was much more common in DCCR treated patients versus placebo. This, necessitated some of the girls to do some laser hair removal or maybe some extra shaving. The boys loved it, but it was, in my opinion, it wasn't above and beyond what you get with growth hormone in terms of extra hair growth, but it was there. And then peripheral edema, again, lower extremities tend to get some swelling, especially it looks like in adults. And again, that, was more common in DCCR versus placebo. And then of course, the high blood sugars, as I discussed. So the safety profile of this drug was consistent with what's expected. I mean, it's exactly what we expected to happen with the drug. And most of the events were very mild, or what we call grade 1 in severity. There were no grade 4 or higher events reported in the study, and there were no serious unexpected adverse events. So those of you who might be endocrinologists in the audience will agree with me that the potential of reduction in hyperinsulinism is really quite huge, because the hyperinsulinism going down will allow for decreased leptin resistance, and also the body fat goes down, which causes decreased leptin production. And then insulin resistance can in and of itself cause a lot of problems, again, that we kind of think of as part of Prader-Willi syndrome: hypothalamic hypogonadism, cognitive dysfunction, mood disorder. And so by increasing insulin sensitivity and reducing hyperinsulinism, the potential of these pleiotropic effects in the syndrome is quite huge, actually. And so it will be interesting to follow these patients over time to see if this does bear out with any changes in the natural history of pubertal progression, of mood disorders, and of cognitive function. And so in conclusion, the analysis done addressing the impact of COVID-19 showed statistically significant improvements for DCCR versus placebo in all of both the primary and secondary endpoints. It also improved the common behaviors that we often see in Prader-Willi, like anxiety, aggression, compulsivity, rigidity, and also improved body composition and adipokines. The safety profile was as expected, and it was generally well tolerated. And I think that's it. Oh, no, it's not. 2 more slides. I just wanted to say thank you to everybody who participated in the trial. It was a pretty intense trial, especially the C601 part of it. And these kids here, these are Florida kids, and they traveled from all over the country to participate in the trial. And it really, and I know they did every place. So it was really above and beyond for them to do this. And then I also wanted to acknowledge all the sites that were part of the trial. There were 20 in the US and 9 in the UK. And now I'm done.
Thanks so much. Excellent presentation. I have to say, in full disclosure, that I also have consulted for Soleno on some of this work. So I wanted to bring that up. We had one question. Did any patient have the HbA1c rise above 7%, requiring the patient to have the drug dose lowered or treatment initiated?
Yes, it did happen to a very few patients. I'm not sure how many, but yes, I do know that there were a few that did have HbA1c rise above 7% and required their dose to be lowered. However, at my site, there was one such case, and she has continued on study at the lower dose and hasn't needed subsequent dose adjustments. And her A1C has come down back below 7.
Very good. And so, what was the age range of patients involved in the study? Any differences in hyperphagia between patients of different genders?
Who genders? I don't know. That's a good question. I have no idea. But age range was 4 and above. Obviously, you know, there were probably higher hyperphagia questionnaire scores in those who were older versus younger. But gender, I have no idea.
And did you see edema reduce over time as the lean to fat ratio went up?
I believe that the answer is yes. I actually didn't have any edema at my site, so I don't know for sure, but I did. I mean, so I had one patient who had baseline edema because of his weight, and it did go away over time as his lean body mass improved and his fat decreased, and he was able to move more, and then the edema got better.
Okay, and so we're getting a lot of very tactful questions about the FDA and about when
I'm not answering those questions.
when the drug will be ready for market. And I kind of know the answer to that. So,
well, the answer is I don't know.
You don't know exactly, and I knew that you would say that. So, but we nonetheless, I think those are the main questions that we have gotten here. Will there be any additional studies for young PWS individuals who have not yet experienced hyperphagia? That's a good question.
It's a very good question. I do not know the answer.
Well, and you know, I imagine hopefully there will be more studies of a lot more groups, and we'll be able to see it.
I would hope so. Yes.
So, all right. Well, I think we're in good shape. But Dr. Poggi, do you want to come on and ask any questions or review anything?
Do you want to say congratulations, Jen, for talking fast enough that you finished on time?
Well, I mean, this is obviously a fantastic project and, you know, very exciting new prospect for treatment. I was really interested in if you had any further comments on the acylated ghrelin. I thought that was really interesting how you're talking about how you didn't see any kind of compensatory effect there. And it seems like that's a really key mechanism. It might be kind of a technical question, but it just seems like that's one of the many exciting findings in the study.
I agree 100%. I think it was really, I mean, to me, that was actually one of the most significant sort of lab findings, if you will, was that there was no compensatory increase in acylated ghrelin to go along with the decrease in body fat and the decrease in leptin. So to me, yeah, I think that was a key finding in the study.
Yeah, thank you very much.
We do have one question about subtype differences. Did you guys see anything there?
Yeah, I don't know the answer to that either. I'm sorry. I am sure the company knows the answer to that, but I do not know the answer to that.
All right. Well, I think we can close out the session. Dr. Poggi, do you have the final slide? I think, thank you so much. We've got our next presentation coming up in a few minutes. It'll be Olivia Veach talking about the same data set, I think.
Awesome. Thank you.